Hello and welcome. My name is Darlene Jenkins, and I will be acting as moderator for today's webinar entitled Health Reform and Homeless Populations. What does the law do for you? This webinar is a production of the National Healthcare for the Homeless Council with support from Health Resources and Services Administration, Office of Special Population Health. The webinar is scheduled to be an hour presentation with the last 15 minutes reserved for questions and answers. Now I will introduce our presenters. Our first presenter is Dr. Barbara DiPietro. Barbara is the Policy Director for the National Healthcare for the Homeless Council and handles many issues related to how the health reform law impacts homeless populations. In addition to working with us on national issues, she also works for the Healthcare for the Homeless Project in Baltimore City. So she is able to see how health reform is unfolding at the state level and also try to improve how health services are delivered to patients who need care. Our second presenter is Mr. Joseph Benson. After going through homelessness and recovery, Joseph began working for the agency that helped him to become stable. He currently coordinates and volunteers at the Search Homeless Services, where he is also the coordinator for the Volunteer and Community Outreach Program. Search is an agency that works to engage, stabilize, educate, employ, and house individuals and families who are homeless. Joseph is also an agency speaker for the United Way. In addition to this, Joseph has worked to assist homeless individuals to register to vote, even securing transportation to get them to the polls. Joseph is a voting member of the Healthcare for the Homeless Houston Board of Directors and helped to create the Consumer Advisory Board for the Coalition for the Homeless in Houston. Joseph is involved in many of the National Healthcare for the Homeless Council's committees and serves as a member-at-large for the National Consumer Advisory Board. With those introductions, I will now turn it over to our first presenter, Barbara.
Thank you, Darlene. Appreciate that. Was curious, just as we go into some of the details of the health reform law, that let's take a step back for just a second and talk about what the real goals of health reform are to begin with and what has brought us to where we are now with the Affordable Care Act. So with our healthcare system in general, we're trying to increase costs, or rather, we're increase access to healthcare services. So we want more people to have access to care. We want people's health to get better, both at the individual level and in our greater communities. We want there to be lower costs, both to individuals themselves, so people aren't spending as much of their personal money on healthcare, but then also so that we're reducing total spending for the entire system, because I think most people have heard that we're getting higher and higher healthcare costs, both for families and for the system, and so that's unsustainable. And then at the same time, we're also trying to improve the quality of health care that everyone gets. So with this in mind, these overarching goals, we have been for decades now in the United States trying to figure out how can we fix a current system to get us to achieve these goals. Now, I think everyone appreciates we have a complicated political system, we have a complicated healthcare system, and so it's very hard actually to make changes. With that in mind, 2 years ago, we signed the Affordable Care Act, or sometimes called the ACA. And this is really the first substantive, really big policy change in our healthcare system. And I think this is why it's created so much change, and I think a lot of change comes to then having a lot of debates. A lot of people have opinions about what we need to do to achieve those goals that I talked about. So when the law got signed in, it's a very large law, again, about 1,000 pages of legislation, so it takes a long time to read through. but it's a complicated system. So it's hard to change a complicated system in a simple way. But we really want to focus on some of the major components of the Affordable Care Act, in particular for us in the healthcare for the homeless community and for people who are experiencing homelessness. The Medicaid expansion is really the biggest part of the law that we're interested in. And this is public health insurance for people who are very low income. The law also has other sections. There's new health insurance rules, largely focused on private health care, but allowing your children up to age 26 to be on your health insurance if you're in the private market, not being able to deny you health insurance if you have a pre-existing condition. Some of those things, that was really important under the new health insurance rules. There's help, income supports for people who need to buy private insurance, maybe not qualifying for Medicaid, but having higher incomes. Again, help for that, to subsidize that. There's money in the law for new healthcare jobs. And I know that jobs in the economy is something that's really on a lot of people's mind. We're trying to build a system that has more doctors, more nurses, more dentists, all the people that we need to have in place so that as we expand insurance and then people go to use that insurance, they actually have an adequate number of people who can give them health care services. So you need more jobs. And then there's a lot of other pieces in the law that try to achieve those goals about improving care, lowering costs with small projects that will see if things work, and demonstration projects, trying again to figure out a way that we can change the whole system. So really, even though the law is large and it's gotten a lot of attention, these are really the major components of what's in it. When we look at where we are right now, so it's been 2 years, we actually still have not seen the biggest changes that the law has to make. In fact, the biggest changes don't take place until the year 2014. And while that seems like a long way away, it's actually only a year and a half now. So January 2014 is not too far away. But at the same time, there's been so many mixed messages and misinformation and so much out there that most Americans do not know what is in this law. And yet, at the same time, many people have a very strong opinion. So we're trying to, through this webinar with our group of folks, to really try to get out just some educational information so that people are understanding what this law is trying to do. Now, you've heard probably about the Supreme Court hearings, so we'll talk about that real quick first. The Supreme Court is still looking at this law, and there's 3 questions that they're considering. One is about the Medicaid expansion, so that's obviously the most important for us. We're expecting to hear that decision at the end of June. So at the end of June, we will hear whether this all goes forward. But we're really optimistic, in particular, about the Medicaid expansion. So we're continuing to do these educational sessions so that people understand. Meanwhile, the Obama administration, you may have heard this law sometimes called Obamacare. It got passed under the Obama administration. They're continuing forward to make rules, clarify details that are not in the law, and really try to give states the information they need so that they understand how to implement this law at the local level. And at the same time, Congress is also looking at, again, it's very political, so there are efforts to try to block pieces of this law, repeal the law itself, or to do things like take away funding from key parts. So these are all the kind of the moving parts right now that we see. We're hoping that a lot of this can settle down at the end of June when we hear from the Supreme Court. Now, if they go and they take away pieces of this law, there's some things that might change. But for right now, we're really trying to go ahead and act as if this is all going to be implemented. So let's talk a little bit then about Medicaid expansion, and we'll talk about who's eligible. So right now, as the law currently stands, most low-income children and pregnant women and people who are disabled, and even in most states, some parents of children, again, all low-income populations, those are the folks that are currently eligible for Medicaid. But as most people know, particularly if you're listening to this this webinar now, most people experiencing homelessness are not eligible for Medicaid. And in fact, usually you have to prove a disability in order to get health insurance through Medicaid. What the new law does, and this is the most important piece, is that it makes eligible people, most poor people who just based on your income. So moving forward into the new system, your eligibility isn't based on whether you have kids or whether you have a disability, but it's just based on your low income. They've established a level at which you can then be eligible. So if you are earning, if you're a single person and you are earning about $15,000 a year or less, then you will be eligible for Medicaid if you also are a U.S. citizen or a legal resident who's been in the country for 5 years. So it's both your citizenship and your income. Now, if you're part of a family, like for instance, if you're married or if you are single but have a child, then the level for eligibility will change depending on how many people are in your family. So the larger your family, the higher your income can be, and you'll still be eligible earn up to about $25,500 a year and still be eligible. So this is really the biggest change. Now, in some states, they've gone ahead and changed Medicaid early. So if you're listening to this in Colorado or in places like Massachusetts, of course, which has really gone a lot further than in other places, you may have already started seeing Medicaid be expanded early. But for most states, it's really not going to happen until January 1st, 2014. So this is the biggest piece to remember, that a lot of people who have been not eligible for Medicaid in the past will now be eligible for Medicaid and getting health care. So because of this increased eligibility, we're now going to be serving a lot more people in Medicaid. And remember that sometimes you might not call it Medicaid where you are. For instance, in Tennessee, I know they call it TennCare. In Maryland, a lot of our Medicaid is called Health Choice. So sometimes Medicaid has got a different name. And in some states, there are other smaller programs that may offer some coverage but not comprehensive coverage. An example here in Maryland is the PAC program, a smaller coverage program that's not full insurance, but it might give, cover just little things. So just keeping that in mind. But Medicaid right now in the entire country, 1 in 5 people in this country are covered through Medicaid, and that's who pays for their health care. This expansion to the new people based just on income is going to add up to 20 million new people into the Medicaid program. And so I think you can appreciate that this is a big expansion. So now after this expansion, instead of 1 in 5 people getting their insurance through Medicaid, it's now going to be 1 in 4. And this is a tremendous leap forward in covering people who have traditionally had no health insurance. Amongst people who are homeless, 2 in 3 people are not insured. And so when we think about the people who have the most to gain, it's the community that lacks housing. This is really the largest benefit in the health reform law for people who are low income. So really want to emphasize some of that. You may also get your health care through other programs. So there's Medicare and the VA and veterans benefits. Medicare does not change eligibility. The health reform law does not change it. It does offer preventive services free of charge, and it does change things behind the scenes, like how doctors get paid or how they exchange data. So information about your care, hopefully you will not be able to have to go all around and do the same tests 2 and 3 times, for example, that they'll be sharing information. It's those kinds of changes that the Affordable Care Act makes. Similarly, in the VA, the law does not change veterans or TRICARE insurance. Now, it could be, though, that if you have VA care, it may not cover everything you need. And so you may still be able to get some services through Medicaid. So you might be able to have both. Ask your case manager about that. But we want to make sure that everyone is connected to all of the health care services that they could be. And again, I know not everyone who's served in the military thinks about themselves as a vet, but if you have served, please make sure that you are connected to VA services. That's really important. So when we think about signing up, how do we get onto Medicaid? How do we, do we get our Medicaid card? The law makes a lot of changes about how you sign up and enroll in Medicaid. It requires it to be a lot faster and a lot simpler. And the biggest piece for us is that you're not going to need paper documentation. So you no longer have to have, going into Department of Social Services, a copy of your paycheck or a utility bill, which for many of us is very difficult to find. You don't have to have your physical birth certificate or your Social Security card, but you do need to know that information. And so I think what this really helps is that if you lose your materials, if you lose your ID, then you still can do the enrollment. And I think that's really helpful. So remember, if you have all of this information, if you know it, if you have it written down, or if your case manager has it, it'll be a lot easier and faster to sign up. And in signing up, they're also using technology to make that sign-up process a lot faster and easier. So because it's based on your income, if you are getting a paycheck, even if it's a modest paycheck or really small, the Internal Revenue Service, the IRS, the people who track, how paychecks get delivered, they know how much you make. They know, how much people are earning. And so they can automatically verify that through their system. And they automatically know as well, and they can verify who you are and whether you are a U.S. citizen or a permanent resident. So they can verify that automatically through their computer systems. You don't have to provide that information to them. So that is really, really important to remember as well. It's going to be a lot easier. So you can do this online, and you can also do it by phone and mail. There's going to be a lot of computerized approaches that are used in making these changes. But you don't have to do this on your own. There's going to be a lot of help for you, particularly if you don't have a computer, or if you're not comfortable using a computer in the public library or some other place you might be getting services. Your case manager can help you. It'll be really good. You don't need a permanent address. Now, I know a lot of places they ask for an address, and even if we are experiencing homelessness, might be in a lot of different places, you don't need to have a permanent address in order to qualify, and you don't need to prove that you are living in the state, again, by providing some utility bill or something, again, that's very difficult to prove. You can also check no fixed address, and this will be an option, particularly if you're moving around a lot. No fixed address is perfectly acceptable. You don't have to meet with people in person to do an interview. All of this is going to be happening electronically. It's going to be a lot easier. And then they're also signing people up for a year at a time. So for folks who live in states where right now it might be a 6-month, where every 6 months that you have to, re-enroll, they're going to have this now be every 12 months. So again, it gives you a little bit more time, and the re-enrollment process will be a lot easier as well. So that's how we do eligibility. That's how we're going to be signing up. Let's talk about what we're getting, though, and what are the benefits that are coming to us. This is really intended to be just the basics, and it may not be even as generous as the Medicaid services that are currently delivered to people who are currently in Medicaid, those who are disabled or pregnant women or children. For the new group, it's going to be basics, but it'll cover, I think, the most important things. If you go to the hospital or the emergency room, if you need prescription drugs, going to your doctor, and in particular, treatment for mental health and addictions. I know that's really important to a lot of a wide community in the United States, but it's something that's typically left out of a lot of health insurance plans. They're required to cover this. If you need lab work and blood tests or other things, it's going to cover that. And also prevention services. So if you need cancer prevention or all those things that keep us healthy and keep us managing some chronic conditions or even preventing those chronic conditions from developing to begin with, this is all covered. Now, you'll notice that I skipped over dental and vision. This is in the law as a requirement for children only. And I can appreciate that dental in particular is such an important issue for all of us, and adults in particular need access to these services. So I know that Joe is going to be talking a lot after me about how we can be active in our state level in seeing how we can't get some of these decisions changed at the state level. Now, the federal the federal government has set this as a minimum. States have the ability to add to this list. They have the ability to determine the details behind how many times you can go, what are the co-pays, what specific kinds of services behind this. We can really be active in convincing individual states to add dental for adults as well. So I think there's an opportunity for us to really be active. And then when we think about signing up, so it's not just enrolling in Medicaid, but also think about signing up for a doctor or a provider of some kind. Because you have to, when you enroll, you'll have to pick a doctor. Make sure that you don't leave that empty. Make sure you don't skip that question. Because if you do skip it, the system will automatically enroll you to some provider somewhere. And that provider may not be close to where you're staying, may not be someone who offers the services that you need. It may not be someone that you have a hard time getting to, like you have no transportation, they're not on a bus line, maybe they don't understand the fact that you're staying at a shelter, and so they're not flexible with times. So again, really picking your doctor carefully is important. This is someone that's going to be called your health home. And this is a term that's being used more and more about how can we look at our doctor as someone who can coordinate all of our care. So even if we have, for instance, an example would be if I have diabetes and I have depression and I'm also doing some addictions group, and so I'm kind of trying to do appointments for all different things, a health home will link all of those services together. They'll share information. They will talk about my needs together. And so they'll really be looking at how I'm doing as a whole. And this hopefully will get people away from having to repeat what they said to their different providers, 3 different times, going all over the place trying to chase down records and data, that a health home will automatically start coordinating that information with you. So when you go to choose a provider, think about, do you like your current provider if you have one? Do you have good transportation to get there? Are they on a bus line? Are they open during the hours that you're able to see them? A lot of times it's hard to be able to juggle, where we're going to sleep and where we're going to eat and, all the things that we need to do and still fit in time to take care of our health. So it's really important to find someone who's going to be open when we need them. And then do they have the services that they need? It'll be really great if I have the conditions I described before, is there a place I can go that has my medical doctor and my therapist and my counselor, all in one place? So these are some just recommendations to be thinking about when you sign up so that you're really able to pick someone who's the best for you. Talk with your case manager about advice for that and help picking the best person. And really would recommend choosing a health center or a healthcare for the homeless provider. Again, just thinking about the issues that are important to you. It's important also to remember that the Medicaid expansion and what the law does not provide a right to health care in the United States. And there are a number of people who are still going to be remaining uninsured even after all of these changes happen. So right now, there are 50 million people in the country who don't have health insurance. The Medicaid expansion plus some of the other changes that happen will add about 30 million people. So that leaves 20 million people who are still without health insurance after all is said and done. And this is the piece that we really are trying to hope we can get this number down. Now, they are estimating, when I say they, I mean Congress, the people who are in the federal government that put this law together, they're looking at how people sign up for things in the past and how many people don't sign up. So they're anticipating that almost 10 million people will be eligible for Medicaid, will be able to sign up, but then don't. And so these are the folks that we really want to make sure we're, again, doing these kinds of webinars so that folks like you can know that the Medicaid assistance is coming and really be prepared to talk it up with your friends, talk it up with the folks that you work with or that, that you're with in the community, and tell them that this is coming, because we want to make sure that everyone who's eligible for Medicaid can get on. At the same time, there are also undocumented persons in the United States, and they estimate about 6 to 7 are not a permanent resident or legal resident that's been here longer than 5 years, you're not eligible for the Medicaid. And this is one of the shortcomings of the law, is that we're not still covering everyone. Now, some people, you may have heard about the individual mandate, and this is that piece of the law. It's very controversial. It's one of the things that the Supreme Court is deciding, is how is it that we require people to have health insurance? Now, having Medicaid, if you sign up for Medicaid, that counts as health insurance, so that counts toward the individual mandate. But if for some reason you are not able to, or you are not signed up for Medicaid, the way that the penalty for, again, there has to be some penalty for it to be effective. If you are not required to file taxes, so if you earn less than $10,000 a year, and that's the level established this year, then you are not subject, that the penalty, the mandate doesn't apply to you, so you won't get penalized. So for most people listening to this call who are experiencing homelessness or very low income, the penalty doesn't apply to you, the mandate doesn't apply to you. So I want that to be really clear, because I know that can seem scary that you're going to be charged for something that you may not, either have the opportunity to enroll in or just may not understand. And again, all of this is very complicated. This is why most people in the country don't understand this law, because it is very complicated. So I wanted to put some of that, if you had that concern, to rest. Now, when we think about all of these changes that I've just described, there's a lot of work that has now shifted from the federal level to the state level, because even though it's a federal law, a lot of this has to work at the state level. So states are busy trying to implement all of these pieces. And again, I think this is why most of the components don't take effect until 2014, because we need time to be able to put in place all the things that need to happen. So they're needing to build a whole new system to make all this work. They have to make sure it works together. They have to figure out all of the benefit details that I talked about. Again, dental being one that we need for adults. Finding all those new providers and getting all those new jobs in there. And then also changing the culture of Medicaid. So we want to try to change this to be more of a regular health insurance program and not something that has to be stigmatized or something that anybody needs to be ashamed of. Now, I think it's important also to remember that there are community health centers where many of you may already be getting care. Those will continue to operate and serve everyone without regard to ability to pay, without regard to documentation. All of those folks that I described, either documented or eligible for Medicaid, will still be able to get their care at a community health center. So just, again, want to make sure that people are very clear that just because you're not eligible for Medicaid doesn't mean that you won't still be able to get health care services at a federally qualified health center. So then there's a few unresolved questions, right? Because this is still an evolving process. There's a lot of pieces that we still don't know about, but we're working through it as we get the details. So right now, the biggest question is we don't know what's going to happen with the Supreme Court. If they come back and they say that, all of this is got to be redone, then I think we kind of have to go back to the drawing board. And we will communicate with you all about those changes. But we're pretty optimistic, hopefully, that the Medicaid expansion will go through. So that's really what we are focusing on today. Also, we're trying to figure out how will states find and enroll all of these people that are newly eligible. Outreach is really important, and so thinking about how our outreach teams and our community partners can make sure that everyone's enrolled. We think about the specifics of benefits. Again, I can't emphasize the dental enough, and then other things that might not be covered. Let's raise our voices and talk about what our healthcare needs are. And then some things like copays. There might still be copays. Now, if you get your care at a community health center or at a health care for the homeless facility, they may help you with those copays. But again, really talk with your case manager about where you can go to make sure that you're getting the care you need and that people are giving you the help you need on finances. And with that, I'm going to turn it over to my colleague, Joe Benson, who can really talk about what action steps you can take in the community, what your role is, because I've just described for you all of the changes, or a lot of the changes that are happening at the federal level, but Joe's going to really make it real in figuring out, what is your role in making this work for you. Thank you so much. I appreciate your coming to this.
Thank you, Barbara. The next slide says to talk about the action steps. What can we do now? We need to spread the word. As individuals, we need to go and talk to our friends, families, our colleagues, any constituents that we have about the Medicare expansion to make sure that they know that they need to sign up throughout 2014. This is the time to start your planning. We need to be able to talk to your doctors. You want to talk to your providers and your case managers. And there's certain things that you really need to talk about. You need to find out from your doctor, are there any pending tests that you need that handle what physical problems that you have. Find out if they have surgery that's coming up in the near future. You can talk with your providers, like what Barbara was consideration. How are you going to get there? How much the copay will be? These are the things that we need to start talking about now so we can have those things clearly in place once that the Medicaid expansion has happened. Next is telling your story. You know, no matter how large or how big the story, when it comes to the decision makers, they need to hear the stories about the barriers, what worked for you and what didn't work for you in getting in the medical health system, whether it was before the Medicaid expansion or afterwards. You need to be able to go to different public meetings. Start participating in the city hall meetings. I don't know how here in Texas, besides having city government, we also have county government. We have commissioners. Go to the commissioners' courts and talk to the commissioners and to let them know what is working for you and what is not working for you during this Medicaid expansion. One of the things, for example, like what Bob brought up, when it comes to adults, there's not in place a vision or a dental plan in the Medicaid expansion. These are the things we need to let these lawmakers know, that they should be able to involve those things in order to get a whole healthcare system for the individuals. Next is participate in helping mail out letters, the email campaigns. I know a lot of you individuals out there are on the social media, the persons that do the Twittering and the Facebook all the time. Put that information out on those social medias so that the general public would know what's going on. Another way is to make flyers at your local clinics, because amongst the homeless community, a lot of people don't have access to television, they don't have access to a lot of social media, but they do receive the flyers. We need to make sure that those individuals get those type of things so they can know where they need to go and to be able to sign up once this Medicaid expansion happens. Next, we have advocacy groups. I always say start with your local cab. At the clinic that you have that you're going to, you always start at home and then work your way from home out. You have organizations like Healthcare for the Homeless Project that's probably in your community. You can start working there. Go and work with Coalition for the Homeless. You have mental health and mental retardation organizations that you can work with. Other advocacy groups is the Urban League, HUD, because those individuals be helping get that information out. Okay, on the next slide, it says the types of decisions you can help with. The main thing is how the system can work best for you. We need to let the people that's putting the system together know what works and what do not work, so that we can make it possible for the system to work good for all individuals. Like we stated earlier, one of the main things that we probably need to bring up to the individuals that's putting the system together, for adults, they don't have the vision and dental that's in place. And as individuals get older, those are the two main things that we need Because I know for myself, for years I didn't have to wear glasses. Recently I've started wearing glasses, and as I'm getting a little older, I'm seeing that I'm having some dental problems also. So you need to make sure that those things are in there. And then how much is the copay? And if you don't have the copay, who will be able to help you with the copay? These are things that help make the system work better, not only for yourself, but for other individuals also. Um, Once again, where they're talking about types of services needed, you want to check about any testing, things like MRIs and the blood work that need to be done. You're having the surgeries that's coming up. And even under this portion here to let the individuals know that for the adults, we need vision and dental also. And then the biggest thing is what we're going to have to work with is trying to figure out how we're going to care for the remaining uninsured people. Like Barbara was saying earlier, out of the 50,000 people that we have without health care that's here in the United States now, only about 30 million people will be able to get health care. So we still have uh, 20 million individuals that still wouldn't be insured, and we need to make sure that we figure out a system in order to work with those individuals. Next is doing outreach to find people. This is one of the things that hopefully we'll be able to bring some of the silos down that we have, not only in healthcare, but in the homeless community, where even though we're serving the same people, everyone is off into their little niche in trying to provide those services. Hopefully in working the Medicaid expansion, we'll be able to break down some of those silos from where some individuals start working with outreach workers in order to find those people. And one of the things that I suggest if we're having outreach workers on the webinar is that you would probably partner with some of the consumers in the local clinics that you're working with and some of the consumers that you have up under the bridges, because these are the individuals that would know where those uninsured people are living at the time when we go out to see about signing them up. Once again, this next one is help enrolling those who need it. It goes back to making those partnerships not only between the different clinics, the outreach workers, even with the police system, because these are the individuals that work with the homeless community each day, and they know where they have to go in order to find those individuals. Next, you don't have to do it alone. You have many organizations out there that can help you. Like I stated earlier, I always believe in starting at home. Start at your local clinic. Find out if they have a local consumer advisory board and work with those individuals and find out what are they doing in order to work with the outreach workers in those different clinics, and to be along with those individuals to get out on the ground in order to get the information out to the homeless community, because we need to get as many of the homeless community enrolled in this first wave of the Medicare Expansion as we board. And we have a website that you can go to. It's NCAB at nhchc.org. Once you go there, it's a wealth of information that's on that website to tell you about how to partner with the outreach workers on that particular website. Next, working with staff and other consumers in your local clinic. Most people refer to the staff members as case managers. These individuals will be the individuals that you can work with to make sure that you're, for example, in choosing a doctor, they would make sure that the doctor is the type doctor that you need. If you need a cancer doctor, we don't want you to have to go to an orthopedic. We need you to have someone that's dealing specifically with the ailments that you have. And in doing that, those outreach workers and staff members would be able to help you with that. Other community groups that you can work with, they have groups that work with privates such as HUD, the Urban League. Homelessness, you have Healthcare for the Homeless shelters, and you have organizations like Healthcare for the Homeless, council. You also have faith-based organizations that will be out there working also. And groups with real life experience is always very powerful, and they can help each other in finding the community, going up under the bridges, into the vacant buildings, to make sure that these individuals get on this first wave of the Medicaid expansion. And if you need more information, it's always great to go to the National Healthcare for the Homeless Council website. On that website is a wealth of knowledge about healthcare reform and other things that you need. It's located at www.nhchc.org. And anyone that's out there that is not a member, whether you're a clinician, worker, a respite person, case manager, or a consumer, we extend an invitation to you to join us. Our membership is free, and we would love to have you become and be a member. For healthcare reform information, you also can go to www.healthcare.gov, and there's a wealth of information at that website also. Healthcare reform, you would also find there the healthcare reform fact sheet is available on that line. And once again, you have the National Consumer Advisory Board, and it's located at NCAB at nhchc.org. Now, as we're leaving you, the ultimate goals of Medicaid: greater access to Medicaid, it equals people getting health care and services. More health care services mean better health care, and better health equals preventing and ending homelessness. Then as we're getting ready to close, we've decided to extend 3 questions to you all. For once the webinar is over, we do not want you to stop talking about healthcare reform now. We want you to continue this conversation amongst yourselves. One of the questions is, how can you help get the word out in your community? The second question is, do you have a story to tell that might help make the new system work better? And third but not least, how can consumers of homelessness services in your community participate in the decision making? Once again, we truly appreciate y'all taking the time out to listen to this webinar. And once again, I will pass it back to Ms. Jenkins, and thank you.
Thank you, Barbara and Joseph. I will begin the question and answer session at this time. The first question is for Barbara, and it asks, can you talk about the budget impact on states of the Medicaid expansion? How long do the feds pick up most of the cost, and what is the percentage of states, and what percentage are states responsible for?
Sure. I know financing at the state level is a really important issue. Medicaid is also very expensive for states. The law for the newly eligible population, for those who are just coming in under these childless adult category, the federal government is picking up 100% of the costs of that expansion for the first several years. And then what they're doing is they're stepping down incrementally in small doses, little by little, so that over the next 5 years, it will then come down to 90%. So it starts at 100%. I think it goes to like 97, then 95, then 93, then 90, and so you see. But it ends at 90. So from the year 2020 and then onwards, the federal government is picking up the vast majority of the costs of this Medicaid expansion. Now, the point to remember is that for those who are currently eligible, pregnant moms, kids, those who are disabled, the financial responsibility for the states stays the same. So we will now have a little bit more of a complex financing structure at the state level, distinguishing between those who are newly eligible and those who are previously eligible. I hope that answers your question.
Thank you. Our next question is also for Barbara. How will each state address the issue of identity theft if applicants are not required to submit documents?
That's a good question. One of the things that the new law requires is that for you to sign up for insurance, and whether that's Medicaid, whether that's in the private system, you should be able to do that from home. Now, obviously it presumes that everyone has a home, but you should be able to do that over the computer. And I know for me, when I'm here at like my work, I get my insurance through work, I don't have to submit a bunch of documentation to get my piece at work, because they're able to verify who I am. And so what they're doing is they're extending those same practices. Now, if it is conceivable that someone could steal my Social Security number and go and then take out insurance under my name, under my Social Security number, in which case, when I go to then register to get health insurance, then there will be something that happens in the system where they realize that there's been a problem. So we think that it's unlikely, again, is it that, I think it's unlikely that people will be stealing health insurance. And certainly if fraud or any kind of misuse of information is discovered, then that should be pursued as a crime. Certainly identity theft is a crime, and more states are developing laws to prosecute that. So while an issue, I think that it's probably not the kind of thing that will be too prevalent, and certainly the kind of thing that we hope that people certainly don't engage in fraud. So again, it's the kind of thing where when it happens, it needs to be pursued as a crime.
Okay. Next question, Barbara. In our locale, it is becoming quite difficult to find medical providers, more importantly, family practice, who will take new Medicare patients. How will this be addressed? Probably Medicaid patients and how
Medicaid patients, okay.
Yes, and how
One of and this is part of a problem. So we're trying to build a bigger system with more people, more providers who can see more people. At the same time, states are really strapped for money right now. So they're looking for places to cut. And a lot of times what they do is they cut the provider reimbursements, that money that doctors and other care providers get when they provide services. The more they cut that reimbursement, the less likely the doctor is to want to see people with Medicaid, because they don't get paid enough. And in fact, many doctors don't even get enough money to cover the services they provide. This is an absolute issue in making sure that we have enough doctors in the community. So it is an issue not just likely in hearing it's in your community, it's in many communities. And this is where local advocacy and having consumers, I know Joseph might also have an example of where they're really trying to be active in saying we need access to care. And that means the state really needs to think about how it's paying its providers and how it can be increasing that rate level so that people are willing to see people with Medicaid.
Another question for you, Barbara. How are states working to identify and enroll people who might be eligible for Medicaid but who aren't well connected to the system?
Oh, that is a great question, and something that I hope that people continue to talk about. The role of outreach and enrollment is really going to be a big issue as this starts to unfold, particularly coming up on January 1st, 2014. So I would encourage everyone to be active in your advocacy using the techniques that Joseph outlined in asking your state that same question. And not just your state, but your local governments as well. How is your local health department involved in making sure that there are people, outreach teams, that are willing to go out to encampments, under bridges, going to the shelters, going to places where people are and enrolling them into health care, and not just getting them a Medicaid card, but actually facilitating their access to health care services. What we're really hoping is that this is a vehicle toward better health and reduced homelessness if people are able to get the health care they need. So I would, coming back to outreach and enrollment, there's no funds, though, in the federal law that go to states for the new population. States do have money, though, for enrolling children and other populations. So through being creative, states and local governments should be able to identify using their community providers and whatever resources they have to make sure they're finding and enrolling and engaging everyone.
Okay. Thank you. Another question can be either for Barbara or Joseph. Will enrollment be handled primarily at social services, or will enrollment be simplified so much that patients can enroll easily on their own?
Okay. This whole system is designed, or supposed to be designed, so that individuals across the country can enroll themselves into health insurance. So the idea, and this goes back to not needing paper copies of your birth certificate, is that for the general public, they can sit down at their home computer or at the computer at the library or someplace and fill out the application and submit it, and then basically sign up for insurance and then get that card in the mail. Now, community providers are anticipated to be a real help in making all of this happen, because I think not everybody is really comfortable with doing that, and so people are going to need help. There will be people called navigators who can help walk you through that process. Your case manager will be able to walk you through the process. You should be able to have lots of places where you can go. You will not have to physically go to a Department of Social Services to do this. Now, if you want to, you absolutely will have that option. But I think that my impression is that if we don't have to go to DSS, then I think a lot of people are excited to avoid that.
Okay. Another question. What happens in states that have not fulfilled their responsibilities for planning and implementation?
So there are the number of states, actually half of the states are the ones who brought the lawsuit against the law to, they're both fighting the law and implementing the law, kind of under, under the table or behind the scenes. Some states, though, are doing nothing. And this is really probably going to be a challenge for them if we get the green light from the Supreme Court and this continues to go forward. A lot of what I described that needs to change and systems need to be built and all of these new partnerships, those will have to be put in place very quickly. And so for folks that are getting a late start, they're going to have a very quick running pace in order to catch up with everyone else. I'm really curious to see what will happen for those states that have really been fighting these changes. It remains to be determined.
Okay. We'll take two more questions. One is, will Medicaid cover housing costs since housing is a form of health care?
Oh, my favorite question. So, yes, housing is health care, and I think everybody listening to this webinar can give a cheer for that. But if you remember, the core benefits, the minimum benefits that Medicaid has to cover for the newly enrolled does not include housing. Now, where we can get creative is that states do have a lot of flexibility under the Medicaid program to design what benefits they want to design. So when it comes to housing, there's a couple of different options that states have that they can choose to take and still get and get reimbursed from the federal government for those services. And so this can take a couple of different ways. Permanent supportive housing, many of us maybe think of it as housing first, or some of those models. A number of states are using creative Medicaid options to be able to, maybe not the actual rent, although in some cases that might be true and possible, but then also paying for the medical services that are taking place in those housing projects. So it may be a way to offset the costs of Housing First programs. It may be also a way to start thinking about how is paying for rent cheaper than many emergency room costs. So if we can pay $900 or $1,000 in rent, and that avoids 10 emergency room visits, then it might be that some of the Medicaid managed care organizations that will be monitoring all of this will consider that. These are all state-level decisions, and this is why your advocacy and you raising these issues at your local level is so important, because it's without that voice, states may not know to go and pursue those changes. So really encourage your activeness on that.
Okay, and our final question is, how early can individuals try to register? Do you have a date, or is everything waiting on the Supreme Court decision?
I think that some things are waiting on the Supreme Court decision, and like I said, we'll have that at the end of June. So that should give states a lot of advance notice for the ramp up. And so states could absolutely decide that they wanted to do a pre-registration as a way of kind of getting out ahead of the curve so that you don't have so much happening just on that first day of 2014. States could choose to either do a phased-in implementation of full Medicaid, or they could choose to just do a registration with the effective date being January 1. Again, these are state-level decisions, but I encourage you to make that suggestion at your state.
Thank you. This concludes the question and answer portion of the webinar, and I would like to thank both Barbara and Joseph for presenting. And finally, thank you for joining the webinar produced by the National Healthcare for the Homeless Council. The meeting is now closed.